Thank you very much, Dr. Kim, and thank you everybody for being here today. We're going to talk about removal of difficult CBD stones. So ERCP has been the treatment of choice for CBD stones for more than 30 years. However, some stones tend to be difficult, or sometimes we call them recalcitrant. And that is defined as the inability to remove those stones using your standard ERCP with biliary sphincterotomy. So what makes a stone difficult? Well, there are a lot of factors that can play a role into that. So as we said, size of the stone is important, the shape of the stone, the location of the stones. Intrahepatic duct stones are usually difficult. Cystic duct stones are always hard to reach and remove for sure. Sometimes you have a distal stricture with the stone impacted proximal to the stricture, which makes it difficult, and lack of tools that you might need to get this done. The good news is we have multiple factors and multiple modalities to tackle difficult stones, and that's what we will talk about for over the next few slides. So first we will start with mechanical lithotripsy. Baskets are commonly used for stones removal. There are multiple baskets commercially available for clinical use. The one you see on your left hand there is the trapezoid basket by Boston Scientific. Basically it comes in 4 different sizes from 1.5 till 3 centimeters. The opening of the basket, it can be used over short or long wire systems, and it really has a nice flexible catheter with good pushability. The basket on your right hand is basically comes as either 4 or 8 wires, called flower basket by Olympus. This one also has 2 sizes and can be used over short wire, and it has an injection port that helps you to inject contrast during the procedure. The question is, when do you consider using basket? If you have a non-dilated duct with a free-floating stone per se, like here, I think most likely you will be successful using balloon sweep. However, the problem with the balloon, if your duct is dilated, the balloon can simply squeeze between the stone and the wall of the duct. And another example is when you have either a dilated duct or you have multiple stones inside the duct, a balloon sweep is not going to be successful most of the times. And in this situation, basket will be very helpful. Also, I want to remind you, in this situation, if you're using basket, I would start really distally in the lower bile duct and start sweeping those stones first, and then go up gradually, so not to have these stones impacted in the common bile duct. Complications of mechanical lithotripsy or baskets, basically bleeding and pancreatitis can happen. I think the fear of basket impaction and wire fracture is a little bit overrated. It's usually around 4% in the literature, and most of the times this can be salvaged by using emergency lithotripter, although none of us really likes to see that device being used for basket retrieval. Next, we're going to talk about balloon dilation of the papilla, which is another way to help with stone extraction. And what we do is also called sphincteroplasty. And what you do is you use a usually CRE balloon, and you can they use different sizes from 12 to 20 millimeters, and it usually helps with stones which are up to 18 millimeters. You need to have 2 things to do this: intact papilla, and you need to have had a sphincterotomy done. Having said that, doing primary balloon dilation of the papilla is not usually recommended, because it might be associated with a higher risk of severe cholangitis, severe complications, and especially pancreatitis. As a matter of fact, a randomized trial looked at 230 patients and randomized patients to receiving either biliary sphincterotomy or primary balloon dilation of the papilla without sphincterotomy, and there was increased risk of severe pancreatitis in the group that received primary balloon dilation, and 2 of those patients actually died from pancreatitis-related complications. So in the United States, the ASGE recommends doing sphincterotomy first rather than doing primary balloon dilation for stone extractions. So usually it's successful, and really a lot of the times, and we will talk about some challenges. Sphincterotomy can be complete or partial, and complications include pancreatitis and bleeding. It has been looked at, the size of the balloon does not correlate with the risk of pancreatitis. So if you're planning to do balloon dilation of the papilla for stone extraction, just keep in mind the 3 important rules. First of all, try to taper the balloon to the size of the duct. So if your duct is 10 millimeters, don't go over that with the balloon dilation. Just stay around that. Don't go to 14. You can certainly have perforation from that. The second rule, make sure you don't have a stone impacted between the balloon and the wall of the duct, because also that can get you in trouble. And the third rule is, if you have a stricture in the distal bile duct, balloon dilation probably is not going to be effective in that situation. So mechanical lithotripsy is usually effective, but there are a few limitations, which are impacted stone, non-dilated duct, intrahepatic stones, and very large stones. So this is an example, back to what Dr. Kim talked about, going back to the basics. Sometimes if you have an impacted stone, like this patient at the papilla, and all you need is really to get access. So in this case, we did pre-cut with a needle knife to get biliary access, and then as soon as you got in, the stone came out really nicely, so you really did not do anything else. Recently, there has been more talk about stone to duct ratio, and basically what it means is the stone size to the common bile duct size. And this really nice paper randomized patients to either balloon dilation or a laser, published last month at CGH. And they define stone to duct ratio if it's more than 1, meaning that if the stone size is bigger than the duct size, balloon dilation is not going to be as effective. So it's something good to keep in mind. So if mechanical lithotripsy is not effective, we can move to more powerful tools. And luckily, we have a few of them. So EHL, or electrohydraulic lithotripsy, basically what this does is it produces intraductal shock waves. And you require a fluid medium, a lot of irrigation to make this work. And it produces a spark that leads to a stone fragmentation. You certainly need to use direct cholangioscopy guidance to do EHL. It's quite effective, high 90s. You can achieve either complete clearance or partial clearance, and use balloon sweep or basket to complete the clearance at the same session or later session. Laser lithotripsy is just another way of doing it. Some people think it's a little bit more effective. It's very comparable according to a lot of studies. It also produces intraductal shock wave. The difference is this shock wave is pulsed compared to a spark as in the EHL, and the success rate is up in the high 90s as well. Complications of laser or EHL lithotripsy are basically, around 3 to 10% or 12%, and most of them are related to cholangitis. So always remember, when you do either a direct cholangioscopy or laser or EHL, to give your patients a course of 5 days of antibiotics to cover them prophylactically from any infections. So this is a video of laser lithotripsy for a patient with a large stone. So what you need to have a lot of irrigation to visualize this stone very nicely. The 365 micron holmium laser probe is advanced through the channel, and it comes at 6 o'clock, as you see there. Ideally, you want this probe to be 2 millimeters away from the stone to work the best. So the way to achieve that is by touching the stone with the probe, and then pulling the probe a little bit, because if you're on the stone, you will have more of a burning effect, but if you're 2 millimeters away, you'll have the fragmentation effect that you need. And after you do that, we usually use 10 watts, and mostly it's successful or effective, and if it doesn't work, we can go up to 12 watts energy, and that will help fragmenting the stone. After that, we use the balloon to sweep those fragmentations out and clear the duct. Now, if you don't have access to laser or EHL, and you want to take care of the problem right away, you can place a plastic stent in the bile duct, and it has been looked at, has been studied. It's a nice temporary measure to take care of the problem, but it should not be a first step. And preferably place a double pigtail plastic stent rather a straight plastic stent. I think it just helps to prevent migration a little bit more. And according to studies, it certainly helps with subsequent, stone clearance in the future. Now, metal stents can also be used, but for lithotripsy. But this has been studied, and the main question is stenting alone good enough for lithotripsy? And the answer actually is no. There is a randomized study looked at this, and there were more complications in patients who underwent metal stent placement for lithotripsy compared to the standard, and most of those complications were related to the stent itself. So if you want like a quick fix, if you're doing the patient like suboptimal circumstances, or the patient has cholangitis, place a plastic stent and just get out of there and plan the next step from there. There are other situations that we don't have time to get to, but always think about your patient's anatomy. So altered anatomy cases are frankly challenging. Usually people with 2 or post-Whipple patients, we can get to the bile ducts, and those patients most of the times. But patients with gastric bypass anatomy, the rule tend to be very long, and in those situations we cannot easily get there. I think we usually have one of 3 options. We either do lab-assisted ERCP, or we do a procedure called EDGE, which is creating a stent between, or a fistula between the pouch of the old stomach and the new stomach pouch, or we can do usually double balloon assisted ERCP, but those patients are the most challenging. You can also have a patient with intrahepatic stones, which are very, very refractory, and bile cast syndrome is another stone-related syndrome. And recently there was a nice image at New England Journal actually of a explanted liver with bile cast syndrome. It's really nice to look at. Those patients tend to be very challenging, and sometimes they need liver transplant. And in summary, this is my approach for difficult CBD stones. Look at the stone to duct ratio. If the stone to duct ratio is less than 1, you can try balloon dilation of the papilla after you perform sphincterotomy, and you can try mechanical lithotripsy, and most of the times you'll be successful. If the stone to duct ratio is more than 1, probably you will need either EHL or laser, and you might have to put stent if you don't have those. If you have an impacted stone, I think most of the times you will need EHL. If you don't have that, place a stent, and also remember we have other options like extracorporeal shock wave or ISWL that can help to decrease the size of the stone and fragment the stone a little bit. For distal CBD strictures, balloon dilation is not going to be successful. You can try mechanical lithotripsy with other ways, or you can try EHL or stent placement. And for intrahepatic stones, you probably will need EHL, laser, or sometimes you will need surgery or percutaneous options. So in summary, ERCP is the standard of care and usually successful. However, 10 to 15% of CBD stones tend to be difficult. We have multiple modalities, and endoscopic options are highly successful. And even for recalcitrant stones, you can get it done. Thank you.